This is the last lower endoscopy G-Echo session. As you know, G-Echo is hosted by the Kessler Foundation in association with Project Echo, University of New Mexico, and the sessions are held on a weekly basis on a Wednesday. The chat is open to questions. For our last G-Echo session, we're closing with an interesting case, a case that was diagnosed and picked up here at Charlotte Matreke in Johannesburg. And leading us on the journey of the case is Jessica Wing. So she's going to be presenting an interesting case for us. Feel free to post questions in the chat and make it as interactive as possible. Over to you, Jess.
Just unmute yourself. Jessica, just unmute yourself.
Yeah, I'm unmuted.
There we go. All good.
Yeah. Okay, so thank you for having me, everybody. Like Dr. Lala said, I'm Dr. Jessica Wing, and I was a former fellow at Charlotte Matreke Johannesburg Academic Hospital and Wits Donald Gordon Medical Center. So today I'm going to be speaking to you about a unique case presentation, a clinical conundrum. Okay. So we have Mr. ES. He's a 66-year-old male who's retired. He was referred from a regional hospital in Johannesburg to our clinic with the following history: a year of watery diarrhea, about 7 loose stools a day associated with abdominal pain. He had no urgency, no tenesmus, nor blood or mucus in the stool. And importantly, he had a significant weight loss of 35 kilograms within that year. Some pertinent history points. So he does have metabolic syndrome, all three: the hypertension, dyslipidemia, type 2 diabetes mellitus, an increased waist circumference. He is on amlodipine for that, a statin, and metformin. Fortunately, he has no macro or micro target organ damage. He's also known with hypothyroidism, on altroxin replacement therapy for years, and he has had prior spinal fusion surgery many years ago, but he's had no prior abdominal surgery. He is a smoker with a significant PACIA history, but denied significant alcohol use. And he's got no family history, fortunately, of gastrointestinal malignancy. So I don't know if any of the fellows that are on, I think I saw God knows, or a few of the others that I know, what other history would you like to inquire about? If you're too shy, I'll just go ahead. Okay, so some of the history that we wanted to ask further about: did he have a personal history of autoimmune disease or a family history of autoimmune disease, which he denied? He had no significant travel history. He had been in Gauteng for the last 20 years. He has no specific occupational history linking him to toxins, heavy metals such as arsenic that can present with chronic diarrhea. He's had no traditional alternative complementary medicinal use before. He has no known mental health care history, denies laxative abuse, no illicit substance history, and he's had no neurological symptoms such as incontinence related to his prior spinal fusion surgery. Importantly, he also had no food allergies known, and there was no temporal relationship with food to the diarrhea. So on clinical examination, these pictures were taken with his permission. You can see that he has significant oncodystrophy and onycholysis of his fingernails. He's got also hyperpigmentation of the skin. And then looking at his feet, he has peripheral edema, hyperpigmentation of the skin, as well as severe oncodystrophy of all of the toenails. He started complaining of also losing hair or having alopecia, despite previously having a full head of hair at the age of 66. So you can see the significant hair loss there on the crown. His blood results: he had a mild normocytic anemia. His iron studies revealed a mild iron deficiency with a saturation of 13 and a borderline ferritin of 21. His vitamin B12 was also slightly low at 198. Luckily, his electrolytes and renal function were preserved with that history of chronic diarrhea. His liver profile and his function tests were normal except for an albumin, which was very low of 20 grams per deciliter. As we know, the usual is about 35 grams to 40 grams per deciliter on our assays. His HIV ELISA test was negative, and he was well controlled in terms of his comorbidities. His HbA1c was 5.1%, his lipogram is normal, and he was on the correct thyroid replacement therapy. He was euthyroid. Because we're thinking that he might have, an autoimmune pathology, we did look for his thyroid antibodies, which were negative. He did have a positive ANA of 1 in 160 with a homogeneous pattern, and a positive anti-double-stranded DNA that was only tested once. However, his C3 and C4 were normal. He had a raised CRP of 10. His ANCA was negative, and his other connective tissue markers, such as Rho, LAR, Smith antibodies, were all negative. Importantly, his anti-TGG were negative, but his IgA, IgG, and IgM were all marginally low, which we know can affect the anti-TGG titer. His stool MCNS was negative for pathogenic bacteria and parasites, and his C. difficile antigen, GDH, was also negative. Importantly, his stool alpha-1 antitrypsin was markedly elevated, and his urine PCR was actually not significantly raised at 0.035. So we know he wasn't losing protein from his kidneys. It was coming from the intestines. Okay, so what is the definition of PLE? We know now that he's probably got the syndrome of protein-losing enteropathy. We don't have his diagnosis, but we know that he has the syndrome of protein-losing enteropathy. So this is characterized by an uncompensated loss of plasma proteins in the intestine. It's indicated by an elevated alpha-1 antitrypsin level in the stool, and it results in a non-selective pan-hyperproteinemia in the absence of significant liver or kidney disease. Just a reminder, there's two main principles in the pathophysiology of PLE. The first would be any mucosal damage, which results in the inability of your intestinal epithelium to retain proteins, fats, lipids, micronutrients, which all leak out into the intestinal lumen and result in loss. And these can be from erosive and non-erosive causes. So erosive causes, namely Crohn's, peptic ulcer disease, pseudomembranous colitis, infectious colitis, and then non-erosive diseases such as sarcoid amyloidosis. And then your second main cause in your pathophysiological mechanisms is abnormal lymph flow in your intestine. So that's usually due to disruption of the central lacteal of your intestinal villus. So it becomes ectatic, disrupted, and dilated, resulting in backflow of lymph into your intestinal lumen. And this results in massive losses of protein, lipids, micronutrients, and immune cells. It's usually the intestinal lymphangiectasia component usually results in marked losses as compared to the erosive and non-erosive epithelial causes of PLE, just to keep that in mind. Okay, so what are the complications of PLE? So looking at our patient, he had all of them: malabsorption, protein energy deficiency resulting in malnutrition. He had micronutrient deficiencies, and on refeeding the patient, they are at risk of getting refeeding syndrome. So to be aware of that. Infections, as they lose their immunoglobulins, their neutrophils, their plasma cells, their complement proteins. Venous thromboembolism is one of the top causes of mortality in patients with protein-losing enteropathy. They lose their protein S and C and clotting factors within the intestinal lumen as well. And then renal dysfunction from the severe chronic diarrhea. And then the complications related to the etiology of the syndrome, as well as depression and psychosocial isolation. Okay, so what is our differential diagnosis at this point in time? So we're thinking along the line of an autoimmune disease. He does have positive serology in the form of a single ANA that was positive and an anti-double-stranded DNA that was positive. He's also known with hypothyroidism despite having negative antibodies, and his vitamin B12 is slightly low, which may suggest pernicious anemia. Okay, so could it be Crohn's disease, inflammatory bowel disease as a cause? Could it be celiac disease, despite having a negative serology? It could be seronegative celiac disease. It could be a systemic vasculitis associated with SLE. It could be infective. We live in South Africa. Tuberculosis can cause non-erosive, infiltrative, protein-losing enteropathy, but that is rare. The more common infective cause is Whipple disease, but that's not common in South Africa. Malignancy is always on the cards. He has weight loss, a year of diarrhea, mild iron deficiency. Heavy metal poisoning, specifically arsenic, can give you hyperpigmentation and chronic diarrhea, which he denied exposure to. Amyloidosis could be a non-erosive cause of protein-losing enteropathy, as well as skin changes and hair loss. And then Addison's disease, hyperpigmentation as well, chronic diarrhea. Okay, then just looking at this slide, these are slides of the etiology of protein-losing enteropathy. And looking at our patient, we're mainly looking at Crohn's disease. It's quite frequent there. SLE, it's a less frequent cause, approximately 3% of the causes of PLE, so not very high on our cards. Inflammatory disorders, graft versus host disease, he doesn't have. He could have Menetrier's disease or hypertrophic gastropathy. That's exceptionally a frequent cause of protein-losing enteropathy. Celiac disease, his serology was negative, but we haven't ruled it out yet. We haven't done duodenal biopsies. And then just to note that malignancy is quite a rare cause of protein-losing enteropathy. So we are more going down the route of inflammatory and autoimmune disease at this point. Okay, just as I mentioned, Whipple's disease is the most common infectious cause of protein-losing enteropathy, and other sorts of infections are less common cause of protein-losing enteropathy. This is a slide. It's just to show basically the algorithm of where you would go in diagnosing protein-losing enteropathy. So you roll out liver, renal, and renal disease and catabolism and sepsis. Once you've proved that you have a high stool alpha-1 antitrypsin, you then go on to look for nutrient deficiencies and look for the likely diagnosis. And that can be obtained either through imaging or through endoscopy. So if you're looking for a lymphatic cause, you would look at imaging. So you're looking for pleural effusions, pericarditis, pleural ascites, etc. And then if we're looking for mucosal cause, we'd be looking at an endoscopy. So we're a gastroenterologist, so we opted for a endoscopy. And this is what our gastroscopy showed. So there's our pylorus, and around you can see all this inflamed tissue. I don't know if anyone on the chat wants to give it a go, if they want to describe what they're seeing.
Feel free to unmute or just put your hand up if you want to comment. You don't need to even say what the diagnosis is if you're not
No.
sure. If you just want to describe what you see, that's also fine.
Just just on those pictures, either you could have multiple polyps or you've got enlarged gastric folds, and with the history, one would worry about Menetrier's disease.
Yeah, I agree with you, Sia. So it could be polyps or it could be hypertrophic gastric folds. But if you look at the intervening mucosa, it doesn't look as diffuse. So, and these lesions are kind of strawberry-like and protuberant. So it's more in keeping with polyps. I don't know if you could maybe describe what type of polyp you think they are. So it's multiple diffuse polyps.
Multiple diffuse, and
And they
does
all
it
look
involve
like this.
the antrum or not?
Yes. So here's the pylorus over here. So it's involving this entire antrum.
Okay. So those would look like hypertrophic or hyperplastic polyps. Yeah.
Yeah. So yeah, they don't
Okay.
look like
Hyperplastic.
adenomas, and they don't look like fundus gland polyps. They are these large strawberry-like lesions with large dilated cysts in the middle. So the pits in the middle you can see are nice and dilated. So just keep that in mind. I'll show you the colonoscopy now, and the intervening mucosa is also quite involved. Okay, so this is his colonoscopy. So he had the same lesions throughout the colonoscopy, but it was less dense than in the gastroscopy.
So it looks literally like the skin of a strawberry. A strawberry has that little
Mm.
central pit in the middle and then a red area around it. So you can see Even on NBI, you can see it beautifully, those central little white spots in the NBI picture, and you can see the dark rim around it. The dark rim is the pink around it, basically.
Yeah. So does anyone want to guess what kind of polyp these might be? And they diffuse throughout the GIT tract. Okay. I'll go on to the histology. So I think the endoscopists will know more about the endoscopy rather than the histology, but essentially this is the histological picture, and it shows dilated cystic ducts and mild distortion of the glands, and there's a non-specific inflammatory infiltrate as well in the lamina propria. So there's no dysplasia, so an inflammatory polyp likely. Then we got the experts to have a look, and they showed haematomatous features, exactly. So it's edematous stroma, there's non-specific inflammatory infiltrate. The glands show these large cystic dilatations like Dr. Lala was showing you with that central nice pit and branches. There's no dysplasia. And importantly, the areas of the intervening mucosa are also inflamed and edematous, and there's mild irregularities of the gland. This is important because when you discerning between juvenile polyposis and another haematomatous syndrome, usually in the juvenile polyposis, the intervening mucosa is normal. Okay, so just remember haematomatous features. Okay, so we did do a video capsule endoscopy. I apologize that I actually don't have the video for it, but there are multiple haematomas, but they're less confluent and they're inflammatory and haematomatous. So they're sparser, but they're all throughout his GIT tract. Okay, so just a reminder, so some haematomatous polyposis syndromes that are inherited. So Peutz-Jeghers syndrome, juvenile polyposis syndrome, Cowden disease, Banner-Ruvalcaba-Riley syndrome, and then neurofibromatosis. Okay, so these are inherited syndromes, but not many people know about the non-inherited haematomatous polyposis syndrome, which is coming to our diagnosis. So I don't know if anyone on the chat wants to share what they think the diagnosis might be.
The clue is in the skin.
And the history, yeah, chronic diarrhea, skin changes, and polyposis.
The nails and the hair loss.
And the hair loss, yeah.
And there was
Could I
very,
give it
very
a try?
famous. There was
Yeah,
a very
Is it
famous-
okay? Cronkhite-Canada syndrome.
Yes, well done, Lillian. Well done. Okay, so it is a very rare disease or syndrome known as Cronkhite-Canada syndrome. It was found by, diagnosed by Cronkhite in Canada in 1955 only. It's very rare. There's 500 cases worldwide. So you'll see the literature is very sparse. So it's a non-inherited inflammatory polyposis syndrome, and it's associated with a protein-losing enteropathy, as we know our patient had, and then ectodermal or cutaneous manifestations in the term of oncodystrophy, hyperpigmentation, and alopecia. The pathophysiology is very poorly understood, but I'll give some evidence later on what it may be due to. Most people think that it's a chronic inflammatory syndrome or it's immune-mediated, essentially. Importantly, why do we care about it? Because it's so rare. It does have a 10 to 20% increased lifetime risk of gastrointestinal cancer. I'll speak a bit more about that later. And it has a high mortality, about 55% at 5 years after diagnosis, namely from pulmonary embolisms, other portal vein, DVT, thrombosis, sepsis from the loss of your immunoglobulins, and then congestive heart failure. Okay, so Cronkhite-Canada syndrome. Okay, so some of the evidence on the epidemiology, most of the evidence, about 75% of my literature search came from Japanese studies. They had a large epidemiological study of about 283 cases that they reported on in 2023. And they found that their average age of diagnosis was 63 years, with no difference between male or female distribution. Interestingly, they did find that mental and physical stress was an important risk factor, as an important trigger, perhaps, for a chronic inflammatory process. Dysgeusia is the dominant initial symptom, so it changes in taste and smell, followed by diarrhea, and then only by the ectodermal changes. But some have reported that ectodermal changes do occur before the diarrhea. And the reasoning for this is because the gastrointestinal polyposis is very closely related to your malabsorption and your protein-losing enteropathy, which then induce nutritional deficiencies and ectodermal changes. This is from that same study, epidemiological study, and it's just basically telling us a little bit about the characteristics. So as an outpatient, the small in the stomach, it was the most dense and the most confluent, and the small intestine, the least confluent, and then in the colon, like fairly confluent. And there were 5 to 10 millimeters mainly, very few more than 15 millimeters. Most of them, as Dr. Lala said, engorged, edematous. Very little of them had erosions or hemorrhaging. And the intervening mucosa between the polyps were half normal, half abnormal. Okay. Okay, so looking at pathophysiology, in 2012 at the Mayo Clinic, a study was done. It was a histological study on 42 haematomatous polyps in 15 patients with Concrete Canada syndrome. They compared those similar haematomatous polyps from patients with juvenile polyposis syndrome and those with spontaneous haematomatous polyps. And what they found on immunohistological staining for IgG4 antibody was that it was significantly increased in patients with Concrete Canada syndrome compared to those with juvenile polyposis syndrome and normal control tissues. And 11 patients were treated with corticosteroids, and 91 received remission on those corticosteroids. Relapse was common on tapering steroids, and 5 patients who achieved remission were then put on azathioprine at 2 milligrams per kilogram a day, and they had no relapse after a median of 4.5 years. So this was one of the studies that kind of alluded to the autoimmune basis for the disease. Okay. And then newer studies in China, I think last year in 2024, next generation sequencing was done on some of these haematomatous polyps in Concrete Canada patients, and they did find increasing expressions of those genes. And those genes are important in innate immune response, extracellular matrix disorganization, a non-specific inflammatory cell infiltrate, increased angiogenesis, and epithelial to mesenchymal transition. So all pointing to chronic inflammatory cause. Okay, so talking about the cancer risk, there is controversy regarding the carcinogenic potential of the disease, namely because it doesn't come from the haematomatous polyps. And I'll explain why later, but prevalence of the gastric and colon cancer in Concrete Canada patients is about 10 to 20%, which is significantly higher than in the general Japanese population. And this is because there's some adenoma-bearing carcinomatous foci within that abnormal tissue. Like I said, it's not coming from the haematomatous polyps, but rather from small adenomas or bearing tissue that then follow the adenoma-carcinoma sequence that we all know. Another thought is that it can be from apparent crypt maturation and chronic inflammation in the lamina propria, similar to inflammatory bowel disease with chronic inflammation, substantially increasing the risk of malignancy. And then another point just to note that detection of malignancy at initial endoscopy would be very difficult. I mean, you all saw the endoscopy pictures. It would be very difficult to pick up dysplasia or abnormal within that colon and in that stomach. And then an important point is that surveillance is actually only practical only after you have decreased the burden of those inflammatory polyps with active therapies such as steroids. Those have proven to be the best in active disease. So once you have treated the inflammatory polyps, you can then reveal your buried adenomas or, occult cancers that you may have missed on the initial endoscopy. And from what the literature I've read, it's possibly you get regression in about 6 months to a year of your polyps on active therapy. So your advanced endoscopy imaging, no one has done any literature reviews, but the one statement that the Japanese made said it may be helpful. Surveillance is empiric after your initial endoscopy, but they suggested to at least be annually, and that this is mainly because your endoscopic recurrence precedes your clinical relapse, like in most gastrointestinal diseases. And then importantly, sustained endoscopic remission is unambiguously associated with a decreased cancer risk. So that's very important. Okay, approach to management, looking at our supportive measures. You can give them an albumin infusion for short-term stabilization. I know in states with our resources, that's not always possible. Compression stockings, you correct their fluid and electrolyte status. Nutritional support is very important, and enteral feeding is preferred. There has been one case report where elemental feeding, exclusive enteral feeding, has reversed the endoscopic polyps, but that was only one case report that I did find without any steroids or immune therapy. You replenish the micronutrients. You give VTE prophylaxis, Clexane while they're admitted specifically, vaccinations, and then there is some literature on prophylactic antibiotics because one of their highest causes for their mortality is sepsis. Okay, so specific measures to eradicate Helicobacter pylori if they are positive, similar to, I think, in Menetrier's disease and a chronic inflammatory gastropathy, which seems to be a trigger. It's not really proven in any studies, but it's empiric. To treat your GERD, PPI, and HR2 antagonisms, but note that these measures don't cause regression of the polyps endoscopically. Our trial of corticosteroids, the Japanese have said about 30, their exact number was 30 to 49 milligrams per kilogram per day. Increasing above 60 didn't seem to improve the polyp progression any further. And obviously, with increased risks of higher doses of steroids, this seemed to be the correct dose. It can be with or without mesalamine. Mesalamine on itself did not prove to cause endoscopic remission of the polyps. And if they're refractory, you can consider azathioprine, octreotide, or cyclosporin A. In the Japanese study that I did read, azathioprine wasn't proven to be successful in causing remission of the polyps, but they did have some improvement with cyclosporin A. However, in the other study in America with the Mayo Clinic, they did see improvement on azathioprine and remission for those 4.5 years. Infliximab and other anti-TNF alpha agents have been tried in small case series with some success. I think there were about 2 patients within the Japanese study that responded to infliximab. And unfortunately, there's been no other data on our other biologics such as vedolizumab or ustekinumab or any of the other mechanisms of action. So it seems to just be the anti-TNF alpha agents for now and infliximab because it's such a rare disease. And this is just a small table from an article in the New England Journal of Medicine that gives you a good overview of your therapy. They do say the surgical therapy can be used in selected cases, but in already nutritionally depleted patients, it's sometimes much more riskier than our medical therapy. Okay, so looking at our patient, what has happened to Mr. ES? He's received a prolonged dose of corticosteroids, and he was weaned to a maintenance dose, I think about prednisone of 10 milligrams per kilogram. He was started on concomitant mesalamine and azathioprine for about a year. This improved his hyperpigmentation, his oncodystrophy, and his alopecia. So all of the ectodermal changes while the active inflammatory polyps were being treated, improving his nutrition and thus improving his ectodermal manifestations. Unfortunately, he did have ongoing diarrhea of about 7 loose stools a day. And because of this, he's now been started on his induction infliximab. When I left, I think he had already completed his induction and his abdominal symptoms have improved. And he's going to be waiting up his follow-up endoscopy, which I think will be at the end of this year. Okay, and these are my references if anyone wants to have a look at some of these interesting articles.
Thanks, Jess. Yeah, for that excellent overview of a very rare disease. Yeah, we did put him on a stepwise or step up sort of therapeutic approach. We started with corticosteroids, and he did well initially, but never quite reached remission symptomatically or endoscopically. So then we added Asacol, salamine, and a little bit better, but still. Then we went to azathioprine, kept him on a good IBD dose of azathioprine for probably over a year, maybe more towards a year and a half. And again, had some improvement, but never quite had remission. I think the problem in our case compared to the large case series studies, and that is he presented quite late. I mean, he sat in one of the peripheral hospitals for quite some time with diarrhea and got to us very late. So he has very extensive disease. Just showed you the pictures. His stomach was completely full of hematomas, his duodenum as well, and his colon. So I think the severity or extent of his disease and chronicity led to severe disease. So we've started him on infliximab, as Jess said, and he's just finished his induction. Clinically, he's doing better, but we haven't yet scoped him. We're going to give him a bit of time, give him at least 3 months on the infliximab, and then go back and see what it looks like. Again, it's as you said, it's a little bit of a nightmare to confidently survey for malignancy, to look for a malignant lesion or malignant polyp amongst the sea of polyps is quite the challenge. So that's quite tricky. Surgery is probably more for localized disease. This gentleman's got quite extensive diffuse disease, and I mean, what are you going to really cut out? You can't cut out everything. So I don't think surgery is a viable option for him besides his malnutrition and being optimized for surgery. He's quite a challenging case. Yeah, does anyone have any comments? Has anyone ever seen Cronkite Canada before? Prof. Thompson, I'm sure you can add something.
I've seen strawberries before, but never strawberry polyps. But I've read about it a little bit in the past. But yeah, these syndromic things, I think it was just interesting. When did you actually scope him rather? Was it quite early in his disease, or was he always sort of, on the fringes of medical treatment because of all this autoimmune focus?
So what happened is there was never an autoimmune focus. It was actually quite missed. He was in one of the peripheral hospitals for probably around 2, 3 years, floating around, diarrhea on and off, and then ended up with our surgical department. And
Oh wow.
our surgical department scoped him, and they noted polyps, but they did biopsies randomly, and the biopsies were then suggesting inflammatory bowel disease. I mean, all it's really showing was probably a colitis, maybe with some eosinophils. So they consulted us. So I saw him in the ward, and when I saw him, the first thing that was remarkable to me is he had no fingernails and no toenails.
Yeah,
And
yeah.
his hair, no fingernails, no toenails, long history, malnutrition, hypoalbuminemia, and hyperpigmentation is what made us suspect immediately Cronkite Canada. And then we scoped him essentially a day or two after that. But he floated around the system for quite some time, as I imagine would happen with these patients. It's not an easy diagnosis to make, and by the time to actually get to some specialized level of care, yeah, they get missed for several years. I see Sianda's hand is up. Go for it, Sianda.
Yeah, no, thanks, Jess, for a great case. I've
Thank
just
you.
got two questions, which one relates to malnutrition. So he's had this protein losing enteropathy, is
Mm.
quite malnourished. Was he assessed for bone disease? Were you worried about osteoporosis, given that he's going to have a long course of
Yeah.
corticosteroids, and then also micronutrient replacement, the vitamins and so on? Did he have that maybe early on in the
So
course?
yeah, he definitely had a vitamin D level which was low, and I think we replaced him empirically even before having that level. So we put him on the 50,000 units per week, and we did check for zinc and selenium, but I don't know if what that result showed because um, in state, those results take quite long to come out. But he was put on, I think, zinc supplementation as well, and some slow mag as well. But yeah, we did do a nutritional panel before for him. That's where I got his iron studies and his folate, his B12 from as well. But he
Okay.
definitely would
And
be at risk for
Basic
bone
nutritional
density
deficiencies.
issues.
yeah,
It was just
then the
anemia and protein.
sorry, but then the second part, with his well, given his degree of immune suppression, even prior to starting him on immune suppressive therapy, what did you check for TB or latent TB? Are you worried about his risk for TB?
Mm. Yeah, it's a good thought. We did do a chest X-ray for him initially, and I think we did worry about TB, especially because it is endemic in South Africa, but it wasn't our top, one of the top differentials. So we did the basic screen, not the sputum because he was not productive, but a chest X-ray and a back tech because he would have gotten infliximab anyway, so it would have been done.
Yeah, he went through essentially the same screening process we put our IBD
IBD,
to
yeah.
follow a TNF. So we basically essentially treated him like an IBD patient. He went through the same process,
Induction
same
cycle.
yeah, the same induction regimen as well, and the same screening process. We generally do screen all of them for TB. So we essentially managed him as if he's got IBD. Um,
Mm.
Again, there's no guidelines on doses and on levels of that you want to attain with biologics. There's really very scanty evidence on
No,
anything
that's
from Guide Canada. So all we could really go on is to try and approach it as we do with IBD, essentially.
Mm.
Yeah, there's really no
yeah.
guideline for these things.
No, I think it's probably even difficult to know what the response to the MAN2 test would be, given that he's got low immunoglobulin levels
Mm.
to begin off with, because
Yeah.
and even the absorption of the drugs, if you give INH, is he absorbing it or not? Mm.
Mm.
Yeah, we'll see. In our experience in terms of TNFs, I think we probably had two patients, maybe three, who did develop TB. Yeah, we've got state limitations as well, as you're well aware of. And even interferon golds are not something we have access to, unfortunately. So yeah, it does become a bit tricky. But we'll see what his response to the TNF is. We tried to actually get him vedolizumab on a compassionate basis because we felt being gut selective for him might
Mm.
be beneficial. Again, no data. We really are just extrapolating IBD for him. But we couldn't get vedolizumab. We failed to get it on a compassionate basis, and we just struggled and just managed to get him on a TNF. So we'll see how he does with that. Clinically, he's better, but we'll see.
Mm.
Prof, Adam, you can go for it.
Sorry. Hi. Excellent talk. I saw there was a big emphasis on H. pylori eradication if it's positive. Sorry if I
Mm.
missed it, but does it play a role in pathophysiology or sort of aggravating of those polyps or anything like that? Or is that just sort of additive symptom that you just need to sort of address?
No, it's not an additive symptom. I think, like I said, with Menetrier's disease or like hypertrophic gastropathies, one of the driving factors for chronic inflammation is H. pylori. So I think it's to do with the pathophysiology. Obviously, in Conquer Canada, they haven't been able to prove a link between H. pylori and the syndrome itself. It's extrapolated to other gastropathies as a, cancer-inducing organism as well. So I think it was just part of the algorithm. Treat the H. pylori if positive. You don't want to add another risk. And if there is a chronic inflammatory process of the basis of its pathophysiology, clearing that trigger or that microorganism that does induce that cascade would be helpful. So it's like a logical thought, but with no proof.
Okay, perfect. And there's obviously no sort of evidence of like, for instance, like a malt, if even if they're H. pylori negative, you could still treat them and expect some benefit. I assume there's not much evidence
No,
for
I
anything
think
like that.
it's only if they're positive. Yeah.
Yeah. Okay, thank you.
Only if they're positive. Yeah. Not
I don't think
empirically.
it doesn't melt away like malts do when you treat the H. pylori. You basically, most malt, you essentially treat the malt or cure the malt with the H. pylori. It's probably the underlying inflammation that just worsens the hematomas in the stomach. But the answer is we don't know. Yeah, I mean, there's not much literature out there, unfortunately. Like Jess said, there is some literature, very little on biologics for these patients, and I would assume also none on even small molecules or JAKs or anything else on these patients as well. But the
Mm-mm.
trust is that it is autoimmune basis. It's an inherited polyposis syndrome. It's not a genetic polyposis syndrome. Prof, you want to come in?
Yeah, I just wondered. I mean, a lot of these autoimmune things start in early life, but this seems to sort of hit the old guys, and the old ladies.
Mm.
So, what's the thoughts about that? Is it just that it's been lurking there in the background until it becomes symptomatic as PLE, or what? Why is it manifest then?
It must be a trigger that happens on later in life, either maybe with hormonal changes or something damage to certain DNA components, like as we all get old, damage some DNA components that manage the inflammatory pathway. And then there's some trigger that has triggered it in them, and no one knows what that trigger is. It's a chronic idiopathic inflammatory disease that no one really knows what the trigger is. They know that now with the next generation sequencing, there are some genes that have come to light, but they're
Yes.
not specific. They're for chronic inflammation. So nothing pointing towards a specific trigger, unfortunately. And I'm not sure why older people get it and not, it's the median age was 63. I think the youngest was like 42. So in their series. Yeah. Unfortunately.
Well, perhaps Walter. Do you remember Walter Cronkite? He was he was one of the journalists on those American programs.
No.
He actually has a school of journalism. I'm sure they could do with him now. Anyway, that's how I remember Cronkite Canada syndrome.
Okay.
Walter Cronkite. It's
That's
spelt
great.
differently, I think. Anyway, on that note, perhaps we should draw a close to your last lower GI meeting of the year. Fascinating. It's always good to get some rare things and stimulate a little bit. But yeah, and it obviously just lots of tests came up with the right answer for sure. And those are fascinating polyps. I don't think you'll ever see the likes of those again all over the colon. So it's a once in a career case.
Mm.
But let's hope you don't see another one because they sound almost impossible to manage.
Yeah.
Anyway, thank you very much. And thanks to all the single speaker and to Vikash, who's put together the whole season of interesting cases and with an endoscopic focus that's second to none. And just remember, we thank the ECHO team that this is recorded and will be available on the Gastro Foundation website. I think next week is IBD. So for those of you who want to continue the autoimmune inflammatory bowel disease package, then I think next week will hold some other further insights, perhaps into some more commonly encountered pathology. So thanks again, and thanks to the sponsors, and have a good week, have a good weekend, and see you next week. Bye bye.
Bye.